Hi, this is Kim McAllister, and welcome to Chapter 2 of our Informatics textbook. We're going to be talking about the theoretical foundations of health informatics. And while some of you may groan at the thought of, oh, this is a theory lecture, I assure you this is really important content. This explains what informatics is and why we do it and how we do it. And so I encourage you to hang in there and take a listen. First of all, when we talk about the theoretical foundation or framework, we have to understand what theories are. And we have three main categories of theories: grand theories, middle range theories, and micro theories. And grand theories are very wide in scope, and they're an attempt to explain a complex phenomenon within a human experience. They can be very difficult to test because they are so complex and have so many variables, but they can also be very foundational for a discipline. Think for a minute about the nursing grand theories, such as Watson's theory of caring, and also think about Orum's theory of self-care. So that's an example of what a grand theory is. And so these grand theories help us understand the basics of informatics and how we use them in a healthcare setting. A middle range theory explains a specific phenomena within the theory, and it generally begins with observation of different concepts and looking at how and why certain things occur. And then micro theory they're very limited and specific to a situation. So it would be like developing a new system of rounding on your unit. That would be an example of a micro theory. So next we're going to talk about the overlapping relationships of technology-based literacy and basic literacy. And we're going to look at computer literacy and fluency. You may have heard of FIT, which is fluent with information technology. And someone who is considered fit has contemporary, foundational, and intellectual skills. And the contemporary skills would be the ability to use apps, such as Word or email, also maybe Hippocrates or some other apps that you may use in your specific job. The foundational concepts would be understanding how and why of IT, understanding opportunities in informatics, of social media, like when you make a political comment, how everybody comes after you on social media, or when you make an error on privacy settings. So you need that foundational concept to really be able to operate and utilize an app or a system correctly, but also to avoid certain pitfalls and problems that happen. Intellectual capability is the ability to take IT and apply it to actual problems and challenges, things that you would see in everyday life. That would be like evaluating a website for their accuracy of medical information or of medication, that kind of thing. Being able to see how the information works. Is it peer reviewed? Does it really work and do what it's supposed to do? And then there's also information literacy, and that's a set of abilities to recognize and utilize information when it's needed. Digital literacy, we don't really see that on the slide, but I wanted to include some information about digital literacy. There's not really an accepted definition like there is of the other types of literacy, but basically it's the ability to find, to locate, to understand and evaluate and create communication and communicate digital information to other people. So it's the ability to use technology effectively and also to create new information. And you also want to be able to utilize and understand the ethical value. This is kind of specific to nursing. When we talk about computer literacy, as a nurse, we want to be sure that we are using the digital information for the good of the community. So let's talk for a minute about systems theory, because this is very important in informatics, because in informatics we are looking at different types of systems that will help with health, such as the electronic health record and the electronic information system that drives the whole hospital or organization. And so a system is a set of interrelated parts that are enclosed within a boundary. That system could be a unit in the hospital. It could be the entire hospital. It could be a subunit within the hospital. An open system is a system that interacts with the outside environment, and a closed system is one that only interacts within itself. It has a very rigid boundary that cannot be penetrated by the outside world. So the whole reason that we have a systems theory, a system, is to provide some purpose and structure and function. And the purpose of the system is your reason for existence. So when you're looking at what kind of system do we want to provide, or what kind of information system do we want to provide for the hospital, we need to look at the information, at the mission statement of the hospital, and that will help to focus and drive what our purpose is for the system. You want to find a system that is going to help you achieve it. The structure is, what will it look like? Is it going to be hierarchical? Is it going to be a web structure? The old hierarchical systems, where you had one main computer that drove everything, and you had a series of computers that would link in through a LAN and interact that way. The web system is what we see more now, and this is where all the different systems can interact freely with each other. And for example, when you do your admission assessment of the patient and you put in the height and weight, that information can also be assessed by physical therapy if they're trying to determine what kind of equipment that person may need. It could be used, it could be sent to the central control that determines what bed a patient gets. If somebody is of a very large size, they may need a different kind of bed, and so they can access that information to determine whether a standard bed or a bariatric bed may be needed. And then you also want to look at function, and that's you want to identify each function that the system needs to perform and how that is carried out. So you have a purpose, which is why are we doing it? You have a structure, which is how are we designing it? And the function, which is what are we going to do and how things are going to be performed. And this is just a depiction of an open system that interacts with the environment. Here you have the environment of the system. Here you have the external environment. And you see that these lines are broken, which means that energy or objects, people, things can move in and out of the environment. So you have your input, which could be your information, it could be your health information, your admission assessment, it could be the medication list, and then you have a process for how that's going to be put into the system and what's going to happen to it. And then the output of that is the information. It could be the energy that's expended by the people working with it. And then it goes all the way back. You have a feedback system which goes all the way back to the beginning. So because a patient has a particular problem, then you may need to provide additional information. And then that information goes in and it's processed and comes out. And then it just goes on and on and on. We want to talk about different types of change in the system. And we have several different types listed here. We have dynamic homeostasis, and this is a process that's used to maintain the balance of the system. We have equifinality, and that's the tendency of an open system to reach a final state. And that state can be reached in different ways. So you might start a system, an information system, in more than one unit at a time, and each unit may um, begin their access to that system in a different way. Maybe one unit only uses the patient vital signs information, and another unit may start with admission criteria. They may start by putting in medication information, but at the end of a certain period of time, maybe a year or 6 months, both of those units are using the information fully and at the same level. So you can have a variety of ways that you start with a system, but you ultimately end up with everyone at the same level. Entropy is the tendency of all systems to break down and not do well. And eventually things do wear out, but entropy can be because the system wasn't set up correctly, because not every possible problem was identified, maybe the equipment wasn't appropriate. And then negentropy is the opposite. That's the tendency of systems to grow and develop. Specialization, this happens as systems become more complex. They can break down into subsystems, and this can be differentiation and specialization. You might have seen that in your hospital. Maybe you had just a general ICU, and then as the hospital grew, you began to break the ICUs down into a medical ICU, a cardiac care unit, and so on. And then you have reverberation, and that happens when change happens across the system. When you have any change within a system, it's going to have intended and unintended consequences throughout the system, and that process is known as reverberation. I think I just went backwards. Chaos theory. This is the science of the unpredictable. These are things that are impossible to control. And you may have noticed as a nurse that that happens quite a bit. You can have small changes in initial conditions that can end up producing drastic results. And these may be things that were never intended in the first place. And with unpredictability, we can't know all the possible consequences of a new system or a complex system. And we can't always control what happens to the system. And chaos theory is also deterministic because all events are ultimately determined by the causes external to the interior. So again, things happen because out of consequences of things that we set into motion, and they're determined that way. We can't always control them, and many things happen that are unexpected. We also have nonlinear and dynamic systems, and that's when the output is not always consistent with the input. And you may have seen that in your patient care, where you have 3 or 4 patients with a similar diagnosis, and they all have very different outcomes, or they may all progress through the illness in different ways. This is also true with systems. We can also have things that are out of proportion to the variables and so forth. Complexity theory. There is a hidden order to behavior of complex systems. And complexity theory looks at how organization resembles an ecosystem, and or it could be a market, such as in the economy, or how it differs from being a machine. People are not machines, and when we work with people in hospitals, we have to establish some type of information system that accommodates for that and allows for that. We have specific traits that are shared by the system, and this can also include insights from chaos theory. And we've learned that learning behavior change is unstable. We don't know, not everyone will change and learn in the same direction. And we also know with complexity theory that all the components of the organization are interrelated. So if you change one concept, it impacts everything else. We have information theories that we want to talk about. And information is the communication or reception of knowledge. And Shannon and Weavers had a specific communication theory where you have, let's look at the diagram. Here you have your information source, which you can think of as the sender. The channel, this is how the way the message is transmitted, how it's carried. It could be through satellite. It could be through your computer system that may be Wi-Fi, or it may be a hardwired system with a LAN connection. It could be a cellular tower. I know a lot of hospitals now use cell phones for the nurses and the front desk to talk to each other, or patients may have your cell number and they call you. So the channel then would be the cell tower. You have noise. This is not part of the message, but it's something that's there that occupies the physical space of the message, such as static or noise in the room. Maybe you're taking care of a patient and you're getting a call, but there are 5 visitors in the room that are being loud, and so that background noise is part of the noise. And then you have a decoder that is going to break down and put the message in a way that can be understood by the receiver who is at the destination. There's also, in this theory, a framework for effectiveness within the communication system. So when you're looking at this, like the information source and transmitter and so forth, when you have to put in orders, your order entry screen, does it capture all the needed elements? If it doesn't, then you have a breakdown at the information source. Is the message coded and transmitted? Is your system functioning correctly? Is your computer system or your electronic health information able to break that information down and transmit it throughout the system so that it goes like to pharmacy or to physical therapy or speech therapy or radiology, wherever it needs to go? And then when that message gets where it's going, can it be decoded? So can physical therapy pull that order up and then process it? Can the pharmacy see what the physician ordered and prepare the medication and then send it to the unit? So all of these aspects of a communication system depend on each section, each portion of the process working correctly. So it's not just a matter now of did they call the order in, or what did the doctor really mean when he wrote this? Or what did the therapist mean when they said they had received information that they needed to perform this type of procedure? We have to have a way of communicating everything and getting it to the place that it's supposed to go. And then the people that get it have to be able to receive it and use it. So next we want to look at the Nelson Data to Wisdom Continuum. And this is part of the different theories of knowledge. First of all, we had Bloom's theory of knowledge, and this is in your textbook, so you can read more about Bloom if you would like to. But basically, Bloom came up with 3 concepts, 3 healthcare concepts related to this, and that's data, information, and knowledge. Then Graves added 4 types of knowledge so that we would understand more about knowledge, and that's empirical, ethical, personal, and aesthetic. And Graves proposed that to develop more of a nursing informatics model. Then Nelson added wisdom, and that's the appropriate use of knowledge in solving human problems. And so the greater the knowledge base that's used to interpret the data, the more information is discussed and disclosed and can be used to process the data. So we have an increasing complexity of information, but we also have increasing interactions of interrelationships. So as you go up this way in the continuum, you can see that all of these pieces interact with each other. So you have data that interacts with information. The data has to be organized and interpreted, and then the information, you have to have someone who uses knowledge to interpret and integrate it into the patient's care. And also you have to have a certain amount of understanding. And then you need wisdom to apply it. So your book talks about a really good example of this, where maybe you have received ABG results on this patient. If you're a new nursing student, you may look at that and understand what a blood gas analysis in BASIC is, but you may not be able to use that knowledge to interpret what's going on with the patient or to anticipate what the patient needs. But as you gain more experience in nursing, then you have more wisdom that you can apply to that information and use that to take care of your patient. So now we want to talk about data. Data can be observable and measurable. Think about your last patient assessment. What things were you able to see? And then what things were you able to measure? You can't see pain, but you can see the impact that it has on the patient. You can have the patient measure their pain on a pain scale. You can say the patient ate some of their food, or you can measure out and weigh what they ate. You can say the patient drank several glasses of water, or you can say the patient drank 45 ounces of fluid during the shift. Also think about data in relevance to subjective and objective data. As nurses, we're always collecting both of those. So if you can put all of those pieces together, that will help you understand what data is. Information is processed data that has meaning. We have different levels of information. We have lean information, which is very basic, very focused on one thing. It could be blood pressure. It could be diet. And then you have rich information that you would use, which takes the lean information and then uses it to interpret. And then you also have acquired information and other levels that move on up. So think about the basic information that you get just from getting a very basic assessment of vital signs, and then the information that you would get from an interview with the patient or with a focused assessment or a general assessment. Think about the information that you get from a patient when you're doing an admission assessment, or if you're home health, the OASIS assessment. And then think about the information that you ask when you go back and reassess your patient. You generally never go back to that full, rich information that you're going to get from that one assessment. Information has different attributes. All of this information is on box 2.4, which is on page 25. And so you want to look at all of these attributes and think how you can use these attributes to determine the quality of your electronic health record. Think about this. Think about the system that you're using in your organization. Does the information that you get have all of these attributes? Is there an area that is missing in what you have? How does that impact your care? How do you think that it would be, what would be a way to obtain that information that you can't get? Knowledge, in addition to the definition that's given here, think about how the differences in knowledge base among health professionals impact the design of your electronic health record. Think about the different levels of education and certification that the different healthcare workers in your organization have. Do they all need the same access to the electronic record? Do they only need a limited? Does limiting what they get impact their view of the patient or their ability to get care? Wisdom. How can a discussion support system be designed so that someone who is extremely knowledgeable and has a high level of wisdom can work with the system, as well as someone who's a novice? What can be some attributes about that system that would make it work for both persons? Should there be some way of dividing the knowledge in an expert or a moderate or a novice user? Could people be experts in one area and novices in other? And if so, how would setting that up keep them from getting the levels that they need at all times? There are a lot of principles of learning that I've listed here. In addition to these, I want you to also remember that people learn in different ways. People have teachable moments that happen at different times. You may need to check off the boxes and show that you have taught a patient something, because that's one of our Joint Commission requirements. And so you have to think about, when is the best time? When is the most teachable time for this person? Remember that different factors can influence learning. It can be what's going on. It could be who is in the room. It could also be what stage of illness are they in. Are they in a particular time where they're very confused and very stressed? Then people tend not to learn. If you can find a quieter time when the patient's more relaxed and not in acute pain or not in the middle of a procedure, that's generally better. Some learners can process large amounts of information at once, and some can only do a small amount at a time. Some learners have varying levels of education and various level of health literacy and information literacy, and you need to tailor your education to that. And the main thing I think that we need to learn before we begin with any of these other principles of learning is that people have to understand that what we are trying to teach them, what they need to learn, is relevant to them. If a patient doesn't see that as relevant or important, they're not going to listen. We also have a variety of change theories. We have to understand change theories in order to provide information to our patient and then help them be able to make changes based on that. You may remember learning about Lewin change theory. That's the unfreezing, moving, and refreezing theory, where you unfreeze, you get the person to see that what I know is not sufficient, and then you help that person move towards making a new change, developing habits. This is the longest part of the process. And then refreeze is when you have that new habit or new information fully in use. There's also the diffusion of innovation theory, which I think is particularly interesting. We have innovators. Oops, here's my notes. Hang on just a second. All right, so we have the diffusion of innovation, and this is kind of the way that everything plays out within the organization. So you've created this new system and you want everybody to sign on and start using it. The first people who are interested in it are going to be your innovators. These are more cosmopolitan people. They're very comfortable with uncertainty. However, technologically, they may be too far ahead of the rest of the group for them to see them as leaders. They're seen as sometimes people who embrace fads that don't last. And they're about 2.5% of your population. Next, you have the early adopters, and that's about 13.5%. These are people who are seen as thoughtful and role models, and because they will sign on to it, then they will bring the early majority along with them. The early majority consists of about 34% of the population. These are people who are willing to adapt to new change, but they are not willing to be the lead. So your early adapters are your leaders. Your early majorities are your kind of your happy followers, and they're happy to get on board and do things. They just don't want to be seen as the leaders. Your late majority, that's another 34%, they're the people that want to embrace something new, but they want to wait until all the uncertainty is gone. So they're very happy for the early adapters and the early majority to get in there and try it. And after all the kinks have been worked out and the problems have been solved, then they're happy to come on board. Then you have the laggards, and that's about 16%. And these are people who will talk about how everything was great before we did this, and we liked this better than, it was much better to have paper charting than computers. And they resist change, and they will not change until they're absolutely have to. In other words, there's no longer any other way to do things except by adopting the new system. We're going to talk about systems life cycle models. In general, a life cycle model describes the stages of the information project and guides the implementation. And you have three basic stages, which is your pre-implementation, your implementation, and your post-implementation. You can also have other smaller steps in between. Generally, there aren't more than 7 stages in the life cycle. So in just the general concept of the life cycle of the pre-implementation, implementation, and post-implementation, they also add the concept of a spiral. And you can kind of get a sense of that through all these arrows that are circling around. And that's because once you implement a change and go all the way back and evaluate it, you never go back to the very beginning. You're always going to have the organization will have grown and developed and changed because of this particular information life cycle. So it's going to start back again at a different place than where it did at the beginning. And so this will go on and on. And you may see some similarity to this in our transitioning over from Genzabar to Canvas. There's a lot of uncertainty, and we've been in the pre-implementation phase while we've been building the courses and getting everything set up. And then the implementation phase is when we begin the course on Canvas, which will have happened when you are seeing this lecture. And then we'll go on to the post-implementation phase when we kind of see how this all works and figure out what worked and what didn't work. There are some specific informatics models that relate to nursing, and we have a few listed here. You have the pyramid model, which has 4 primary concepts. You have just the raw nursing information, what we know from nursing science and nursing practice. We have technology and users, and we have a goal and an objective. And this is built on a pyramid, and it really helps to describe the interaction between humans and computer. Turley's model looks at cognitive science and computer science, informatics, and nursing science. And this is expressed in a model with cognitive science and information science and computer science all in circles that interconnect, with informatics in the very center of the model. And then nursing science surrounds all of it. We have Goodson's framework, which include data, information, knowledge, decision, action, and evaluation. Each concept is a step, so each one is a step up to the final concept, which is nursing management and processing to patient care. So we start out with data and then go all the way up to nursing care. And then we have the IRO model, which has 2 components, which is a 5-phase life cycle. So you go back to the life cycle model, and that's at the very center of the circle. And it's surrounded by evaluation, which occurs throughout the life cycle. So you have the life cycle in the center, then you have evaluation on the outside, kind of like this one. This has the life cycle, and then it has evaluation on the outside. And then it has another circle that has 4 constructs that interact with each other that make sense to nursing. And that's the client, your nursing informatic interventions, your outcomes, and then the physical, cultural, social, economic, and so forth context of the patient. Understand that there are all different kinds of informatics theories, and they are specific to each discipline. So there's health informatics, there's nursing informatics, there's provider informatics, and so on and so forth. So this course, because we are nurses, we're going to focus on the nursing informatics side of health informatics. So I hope this has given you a basic overview to what nursing informatics is and how we operationalize it in care.